Welcome to the Disability Clinic. I'm Dr. Stephanie, a pain and function specialist. Today I'm going to pull back the exam room curtain and explain my process for figuring out what's causing someone's back pain. Back pain is a symptom, a clue that some kind of injury has occurred. But it's not a diagnosis, and it takes some clever medical detective work to solve each patient's case. Keep in mind that good clinicians can achieve this within 15 minutes of meeting a person. I want to share my evaluation process with you because understanding it will help you take better care of your back, which will improve your ability to have other people's backs for as long as possible. You will be learning some juicy medical secrets, but only qualified professionals with specialty knowledge, skill, and experience should be evaluating people with back pain. Remember, this is not personalized medical advice and cannot replace an evaluation by your doctor. It would take way too long to cover every possible diagnosis that could cause back pain. There's textbooks for that. So while we may get to that stuff in the future, today we'll be doing a simplified overview of the most common reason for back pain, which has a fancy name, spondylosis. My evaluation begins before I even meet a patient. I like to check out their mobility as they're coming into the clinic. Mobility is how someone gets from point A to point B. It tells me a lot about how someone's current functional status is, and it's an essential part of the physical exam that's often missed. Are they walking or rolling? Are they using an assistive device like a cane or a walker? Do they seem uncomfortable or unsteady? After introductions, I always start off with, where does it hurt the most? I ask them to rank their most painful regions from most to least bothersome, so I can narrow down at least the top 3 regions of involved anatomy. These regions might fall into known referral patterns, or they can be connected or completely separate. Ranking areas of pain by severity also helps focus the visit on the most bothersome problem. Then I ask 2, when and more specifically how did someone's pain start? Just think of all the ways people can get hurt, and at least one of those will have happened to someone experiencing pain, anywhere, not just the back. Physical injuries include straining, pulling, or stretching, tearing, cutting, pinching or crushing, fracturing or dislocation, and good old-fashioned wear and tear. There's also inflammation after a physical injury or disease, poisoning or toxicity, and loss of blood flow, which can be thought of as tissue suffocation. Typically, people with back pain describe an inciting event, like lifting something the wrong way, a car accident, a bad fall, starting a new exercise program. But sometimes they don't even remember how their pain started. There is another type of injury in which psychology plays a key role, but we will discuss this more in depth in another video. My next question is always 3. What does the pain feel like? There are many words that describe the quality of pain. Stiff, achy, tight, sharp pain is usually due to muscles and bones, while burning, shooting, electrical pain is usually due to nerves. For example, someone might tell me they have achy back pain during the day, but at night their feet feel like they're on fire and they can't sleep. This suggests musculoskeletal back pain, but also nerve pain in the feet. The last clues I need to collect before I do my physical examination are 4. What makes the pain worse and what makes the pain better? These are called aggravating and alleviating factors. Aggravating factors could be things like walking up the stairs, picking up a grandchild, or getting out of bed in the morning. Alleviating factors can be anything that has helped provide some relief, usually medications, heat, massage, or other strategies. So up until this point, I've mostly been listening to the clues my patient is telling me. I know where the pain is, how and when it started, what it feels like, and what makes it worse or better. Now it's time for the physical exam, which reveals the clues my patient can't tell me. We've already done a key part of the physical exam, mobility analysis. Now I'll keep my exam focused on the most painful areas. For back pain, I'll have my patient stand up, if they can, and show me again where their pain starts and where it goes. Visually, I'll scan the area for any abnormalities like asymmetry or hunched posture, skin redness, and swelling. Then I'll ask for permission to touch or palpate the painful areas to assess for tenderness. Painful tight muscles feel like knots, or as I like to call them, taut myofascial bands, that are firm and tender to palpation, which means it hurts when you push on them. Knots can happen anywhere throughout your back core and can affect your posture, your neck movements, and the way you walk, and how much you can lift. Muscle pain may seem simple, but it can be extremely painful and worsen stress, suffering, and disability. It's also easy to overlook if there are other more complicated issues contributing to someone's pain. Next, I'll have my patients go through the normal range of motion of the spine. Bending backward, leaning forward, twisting to each side. and I tell my patients to bend and lean as far as they feel comfortable, and it becomes obvious when a particular movement of the spine is limited by pain. Ow, ow. Pain that limits spinal range of motion can be due to the facet joints or the SI joints. I do my best to isolate and strain the facet and SI joints to see if I can reproduce someone's pain. I do not enjoy causing my patients more discomfort than they're already experiencing, but these pain-provoking maneuvers are very helpful in pinpointing the specific joints that are causing pain. Intervertebral disc injuries can also limit spinal range of motion. Remember, discs are like jelly cushions, but like jelly donuts, if left out for too long, they dry up, they get stale, and they flatten. Flat discs have less shock-absorbing power, making your spinal column less stable and more vulnerable to injury. Flat discs also take up less space between vertebral bodies, which shortens the tunnel where the spinal cord travels. This is partly why we get shorter as we get older. If a disc is significantly torn or herniated out of place, it could be irritating nearby nerve roots or the cord itself, too. Now that I've assessed the muscles, bones, and discs of the spine, it's time to evaluate the spinal cord and nerve roots. Irritated nerve roots will cause numbness, weakness, or neuropathic pain, like burning, tingling, or shooting, along their dermatomes. For example, in the low back, neuropathic pain commonly radiates down the legs. Many people refer to this as sciatica or lumbago, but these terms are vague and outdated. In modern medicine, we call pain along an irritated nerve root radiculopathy. For example, the L5 and S1 nerve roots supply strength and sensation to the calves. To test these nerve roots, I test calf muscle strength while my patients are standing with support for safety. I ask them to go up on their tippy toes multiple times, and if they can't raise themselves all the way up on their toes or they can't tolerate more than a couple of repetitions, this represents true calf weakness. This is a clue that nerve root irritation at the L5 or S1 level may be responsible, and you already know this would mean a possible diagnosis of L5-S1 radiculopathy. Next, I check for abnormal reflexes and special maneuvers called upper motor neuron signs. An important provocative maneuver for radiculopathy pain is called the Slump Test. While my patients are sitting in a chair, I have them slouch over, tuck their chin to their chest, and I lift their leg out straight. This pinches the nerve roots in the lower back as they exit out of windows in the spinal tunnel. A positive slump test reproduces neuropathic pain down the leg, and it's a pretty reliable test for diagnosing radiculopathy. Upper motor neuron signs can also represent irritation at the spinal cord itself. Narrowing of the main spinal tunnel around the cord is called spinal stenosis, and this is more serious because your spinal cord is signaling for your legs, bladder, and bowel, not just muscle and bone. Spinal stenosis can present with pain up and down the spine, weakness, or even problems with peeing and pooping. Doing a physical exam helps me find achy joint pain, disc pain, and nerve pain associated with someone's back pain. All of the things we've discussed so far, wear and tear of the joints, flattening of the discs, and irritation of the nerve roots of the cord, represent a very typical presentation seen in pain clinics and primary care offices everywhere. This is what healthcare professionals call spondylosis. It's an umbrella term for your back is worn out and out of shape. Spondylosis by itself is not a harmful disease. It's actually just the normal progression of aging and part of the human experience. By age 50, which is still relatively young, 80% of people will have visible wear and tear on their spine MRIs, even without symptoms of back pain. Spondylosis is more likely in those with advanced age, inactive lifestyles, and coexisting chronic conditions. Other things that accelerate the degeneration of the back and spine are a history of a back injury, like a car accident, a history of spine surgery, a systemic joint disease like rheumatoid arthritis, or a heavy-duty job like construction. People at highest risk for back injuries are those with balance issues, frequent falls, or a high-risk lifestyle. In rare cases, if there's an injury to the spinal cord, urgent surgical intervention may be needed to widen the tunnel and stop any progression of neurological damage. Spinal cord injury deserves its own video series, but until then, I want you to remember these red flag symptoms that are important warning signs of possible spinal cord damage. Sudden numbness in the groin, like in an underwear distribution, inability to feel or control your bladder or bowels, and sudden arm or leg weakness. If you experience any of these symptoms and you're concerned about your spine health, call your doctor right away or get evaluated in the ER. The type of back pain that most concerns me, no matter what is causing it, is the type that limits someone's ability to sleep, take care of themselves, and stay active and productive. If someone's pain is severe enough to make them fearful of doing their normal daily activities, this is a major threat to their overall health and quality of life. We'll talk more about pain severity and quality of life in the next video. So, now you know my secrets for how I diagnose one of the most common causes of back pain. If you ever have to go see a doctor for back pain, now you'll know what kinds of questions you'll be asked. And if they don't put you through some painful provocative maneuvers or hit you with a hammer, you should ask them why they skipped key parts of the physical exam. Check the description for some more good resources on how causes of back pain are diagnosed. If you have any questions or feedback about this content or ideas for future videos, I would genuinely love to read your thoughts in the comments. If you found this video helpful and you learned something, consider palpating those like and subscribe buttons for tenderness. Thanks for watching.